Hello everyone, my name is Casey Sullivan. I am a rising second-year cardiology fellow at Washington University in St. Louis, and today I'll be presenting an interesting case of transcatheter valve-in-valve replacement for severe bioprosthetic tricuspid stenosis in a transplanted heart. So our patient is a 43-year-old gentleman with a long history of heart failure and non-ischemic cardiomyopathy, was briefly supported with a HeartMate 2 LVAD, and then eventually underwent orthotopic heart transplant in 2012. The initial post-operative period did well, but then 6 months post-transplant was noted to have significant signs of right-sided heart failure and was eventually found to have severe tricuspid regurgitation. He then underwent a surgical bioprosthetic valve replacement with a 31 millimeter Hancock 2 valve. Again, did well for several years and is now presenting with months of progressive abdominal bloating and distension, lower extremity edema, and declining renal function with initiation of hemodialysis, and subsequently is found to have severe bioprosthetic tricuspid stenosis, as we'll see in the coming slides, and was referred to our clinic. So other pertinent past medical history, like I said, the non-ischemic cardiomyopathy and prior heart transplant and tricuspid valve replacement. In addition, had end-stage renal disease and insulin-dependent diabetes that was poorly controlled, a prior pacemaker replaced for complete heart block, and chylosocites. On physical exam, as you can see, he is mildly hypotensive with a blood pressure of 81/44 and mildly tachycardic with a heart rate of 92. He's a frail-looking gentleman with significant jugular venous distension, clear lungs, a diastolic rumble at the left lower sternal border, and significant peripheral volume overload with shifting dullness and a positive fluid wave indicative of ascites, and 2+ pitting edema of the bilateral lower extremities. And then on our transthoracic echocardiogram, we can see a tricuspid valve here with the bioprosthesis exhibiting severely thickened dense leaflets with restricted motion, and a Doppler envelope there showing a mean gradient of 12 millimeters of mercury at a heart rate of 81, consistent with severe tricuspid stenosis. He also had a markedly dilated right atrium, dilated inferior vena cava, and ascites noted. Given the patient's severe symptomatic bioprosthetic tricuspid valve stenosis, he was referred to the multidisciplinary valve clinic for discussion of potential therapeutic options. Due to his multiple prior sternotomies, his calcified pericardium, and end-stage renal disease, as well as his poorly controlled insulin-dependent diabetes, he was thought to be very high risk for surgical replacement of the valve, with an estimated operative mortality in the 15 to 20% range per our surgeons. And therefore he was deemed to be more reasonable candidate for percutaneous transcatheter valve-in-valve tricuspid valve replacement, which is the procedure that we'll be describing in the coming slides. So we begin the procedure here by obtaining venous access and establishing support. An 8-French venous sheath was inserted to the right common femoral vein, followed by a balloon tip catheter that was advanced with some difficulty across the stenotic valve into the RV. Simultaneous RV and RA pressures were made, which you can see on the top right with a mean gradient of about 10 millimeters of mercury. The starter wire was then advanced deeply into the left PA and finally exchanged for an Amplatz super stiff wire with a slight bend that was then advanced deeply into the LPA, establishing an excellent wire support for the procedure. So after support was established, a 29 millimeter Sapien 3 valve was placed onto the loader with the skirt in the atrial position and delivered into the IVC and loaded onto the balloon. The valve was then placed across the tricuspid valve, as you can see in the top right corner here, in the appropriate position. The valve was then deployed at nominal value, landing approximately 90% into the RV with a slight overhang into the RA, and was post-dilated one time with an additional 2 cc's of air, resulting in adequate positioning. Following valve deployment, post-procedural TEE images were obtained, which showed excellent positioning of the valve with no paravalvular leak, marked improvement in valve opening with a mean gradient of 3 millimeters of mercury, no pericardial effusion, and improvement in the RA and RV sizes. As you can see here, good movement and opening of the valve in the top picture here with decrease in that gradient to 3 millimeters mercury in the bottom picture there. Finally, at clinical follow-up, 1 month post-procedure, the patient reported significant symptomatic improvement. He'd had a marked decrease in his abdominal ascites and complete resolution of his lower extremity edema. He was back to doing moderate physical activity, including weightlifting without difficulty or any limitations, and actually was able to transition back to peritoneal dialysis, which was a huge lifestyle improvement for him, and he is now currently actively undergoing evaluation for renal transplant. To conclude with a very brief discussion, patients with tricuspid valve replacements are often higher risk group with multivalvular disease and medical comorbidities. As our patient, that significantly increased the risk of operative morbidity and mortality, and therefore transcatheter valve and valve procedures have emerged as a viable alternative to surgical replacement. This procedure was first described in 2011 by Van Gars using a SAPIEN XT valve via the internal jugular approach, but since that time, experience has expanded to include the MELE valve and newer generation Edwards SAPIEN XT and SAPIEN 3 valves. Selection of the valve is guided meticulously by measurements using TEE and CT. In our experience, the smaller profile and large variety of available diameters of the SAPIEN 3 valve tend to make it our preferred valve. And subsequently, multiple studies have demonstrated that this procedure, transcatheter valve-in-valve for the tricuspid, is technically feasible with high procedural success rates and relatively low rates of adverse events. These are my references, and thank you all for allowing me to present this case.